And I'd like to now introduce Jennifer Taylor-Cousar. Jennifer is the Tuckman Family, a professor in the Tuckman Family Division of Pulmonary and Critical Care and Sleep Medicine at National Jewish in Colorado. She is the co-director of the adult program there. Dr. Taylor-Cousar graduated from Stanford University and completed her Doctor of Medicine and residency in internal medicine and pediatrics in 2002 at Duke. She went on to do both a pediatric and adult pulmonary fellowship at Duke and moved to Colorado, where she obtained a Master of Clinical Science. She has been instrumental in clinical research trials for cystic fibrosis and has been the lead for several trials, including CFTR modulators. She's involved not only with clinical trials, but also in the CF Foundation as an advisor to the Board of Trustees. She has an interest in women's health in cystic fibrosis and disparities in cystic fibrosis and overcoming them. So I'm delighted that Jennifer is here to talk to us about CF Therapeutics, what's going on now, and what will be happening in the future.
Thanks, Peter, for that really nice introduction. And thank you very much for the invitation to speak today. I also want to say thanks to Myra and Abigail. I've never done yoga in my office, but I feel like I need to do that every day now because that was very relaxing for sure. And also thanks to Chris, because that was a really great inspirational talk. So I'm going to be talking to you today about CF Therapeutics, both what's happened recently, as well as what we expect to see in the future. These are my disclosures, most of which are related to the fact that I'm the primary investigator on many of our studies, and I'm frequently consulted to help with clinical trial design. So what we'll talk about first is describing the history of diagnosis and treatment of CF. We need to know where we started to see where we are now. Then describe the changing life considerations for people with CF based on the therapies that have been developed. And then finally talk about the future directions of CF therapeutic development. So stepping way back, there's early European folklore that said a child that tastes salty when kissed will soon die. And then in the 16th and 17th century, there were these case descriptions of children who had very severe malnourishment, steatorrhea or greasy stools, and meconium ileus, so blockage of their bowels when they were born. And we think that all of these were probably cases of cystic fibrosis. Now, fast forward to 1938, when Dr. Dorothy Anderson described CF for the first time. This data is from the CF registry, and on the y-axis is a historical and predicted survival. So what we expect for someone to live, how long we expect them to live. And then on the x-axis is the decade. So you can see back in the 1930s, when Dr. Dorothy Anderson described the disease, people were not expected to live long enough, unfortunately, to even make it to kindergarten. But as CF care centers were formed and as therapies were starting to be developed and used for people with CF, survival began to increase. But up until when Kalydeco was approved, and Dr. Mulgazel talked about that earlier, up until that point, we were really focusing on treating the signs and symptoms of cystic fibrosis. So Kalydeco or ivacaftor was the very first drug that impacted the basic defect in CF. And you can see that survival started to increase even more. And based on the 2020 registry data, the median predicted survival for the first time in the history of CF is 50 here in the US. So how did we get here with these last few years of really improving survival? So all of you are aware of the 2019 approval of Trikafta in the US. So that was based on these two big trials, one in people with one copy of F508del and a minimal function mutation, one that doesn't produce any protein at all, any chloride channel, and for people with two copies of F508del, the most common CF mutation. But then all of those people were invited to go into open label study. So they could actually have drug, whether they started with placebo or not. And that study is going to be 192 weeks. But I have data that was shown at the NACFC 2 weeks ago about what happened in that open label period. So we can get a better sense of the longevity of those great improvements we saw from the early trials. So this first one is looking at the absolute change in lung function in people who were on Alex-Tezaiva. So you can see on the x-axis is the week in the study. So for each of these graphs that I'll show you over the next couple of slides, the first part of it is the placebo-controlled trial, and placebo is in gray, and in purple are those people who are actually receiving drugs. So of course, we know from the data that they had a very rapid improvement, but importantly, when they rolled over into open label, so they continued on their drug, their lung function was maintained at that new higher level. And for people who were on placebo, they also immediately went up, and then that was maintained over the first 96 weeks of the open label study. Similarly, for sweat chloride, we see that there was a rapid improvement in those who were treated, and it stayed about the same in those who were on placebo, but once they were in open label, it dropped, and that was sustained over the first 96 weeks. Also, the same is true for BMI, where it immediately improved for those who were on drug, and then it stayed up and actually continued to go up a little bit for those people in the open label trial. We also want to know how people are feeling, not just the numbers, but how they're feeling when they take a new therapy. And in this trial, we showed that there was a rapid improvement in how people were feeling, so their quality of life based on their respiratory symptoms improved, and that stayed up over the course of 96 weeks. And once people were in the placebo group got on drug, theirs stayed up as well. Now, one of the most important aspects of what the modulators do is improving the number of exacerbations people have, so it lessens it. And why do I say that's so critically important? Well, we know from data from the registry that about 25% of the time, people don't make it back up to their baseline after they have a pulmonary exacerbation. So every single time someone has a pulmonary exacerbation, they're at risk for permanent lung function loss. So we want to prevent that as often as we can. And you can see that in both groups, those who had one copy of F508 or two copies, they had a decrease in their pulmonary exacerbations of about 80%. So that was even out through week 96. Of course, this could be a little bit complicated by the pandemic because people were staying home and wearing masks, but nonetheless, a marked decrease in pulmonary exacerbations for people who were in the trial in the open label extension. And very interestingly is the effect over time on lung function. So we always think of people with CF in the modern era losing lung function at about a rate of 1% to 2% per year. On this graph, on the y-axis, I'm showing you the estimated FEV1, and on the x-axis, time in year. So they use calculations to look at, are people still declining when they're in the open label study? And in fact, people were no longer declining in the open label study. They actually had a little bit of an increase in their lung function. This is the first time that's ever been shown for any drug in cystic fibrosis. So very exciting. Again, it could be complicated a little bit by the pandemic, but this is very, very promising. Now, what about in children? Because of course, those trials were all done in people who were 12 and older, so older children and adults. We also showed this year that Alex-Tezaiva or Trikafta is safe and efficacious in kids who are 6 to 11 years old with at least one copy of F508del. So again, on the y-axis is a percent predicted FEV1, on the x-axis is time in the study. And you can see that even in these children whose baseline lung function was actually quite good, there was this really nice improvement in lung function, and that was sustained over the first 24 weeks of the study. Now, this graph is a little bit different than the ones I've shown you before. So on the y-axis is the proportion of kids who actually had a sweat chloride that dropped either below 60, the diagnostic threshold for cystic fibrosis, or below 30, where we think carriers have their sweat chloride. So this gray bar is looking at what percentage of kids in the study who had one copy of F508 dropped their sweat below 60. And you can see that it was 80% of kids dropped their sweat below that diagnostic threshold of 60, and almost 6% dropped it below 30. And then if you look at the group of kids who had two copies of F508del, 100% of them dropped their sweat chloride in 24 weeks below that diagnostic threshold of 60, and about 43% dropped it below 30. So very, very exciting for what we may see over the future in kids who get treated very early and have their CFTR protein function corrected very, very early in life. So those are 6 to 11-year-olds. What about younger kids? So there are current US approvals in young children, so ivacaftor for kids who are older than the age of 4 months, and Orkambi or lumacaftor ivacaftor for kids who are over 2 years. And importantly, there are studies of Alex-Tez-Iva that are ongoing in kids who are 2 to 5 years old. Something also I think is incredibly exciting, and we'll maybe see more of it, as Dr. Mulgazel alluded to, a lot more people became pregnant in 2020, but there was a recent report at the end of, well, really beginning of 2021 that showed a baby was born to a mom who had cystic fibrosis, and she was being treated with Trikafta, and she decided to stay on Trikafta throughout her entire pregnancy. When her baby was born, it had a normal newborn screen. So the Trikafta had gone through to the baby and the baby's pancreatic function was normal. So the newborn screen was falsely negative. Fortunately, the doctors did check the baby's genetics and find out, in fact, it was homozygous for F508del. So she looked great at birth because she had been treated essentially by her mom's Trikafta. Now she's still breastfeeding and getting a tiny bit through breastfeeding, so we'll see how her course continues to go, but it is very, very promising to see that you could treat a baby very, very early in life and maybe change the ability to maintain their pancreatic function so that maybe they wouldn't need enzymes right away. So at this point, based on the approvals in the US, for people who have one copy of F508del, regardless of what their second mutation is, we have the majority of people in CF who can get a highly effective CFTR modulator, so a drug that impacts the basic defect. So how is that translated into the real world? Because of course, studies choose very specific people with very specific criteria. So we want to know, how is it actually impacting people in the real world? So this is also data from the Cystic Fibrosis Foundation and is looking at pulmonary exacerbations, because one question we had is, did Alex-Tez-Iva change how the pandemic impacted pulmonary exacerbations? Was it Trikafta? Was it because people were staying home? So this looks at that question. So in yellow are the people with CF who were over the age of 12 and eligible for Trikafta with the initial approval in October of 2019. And in blue are the kids who are 11 and younger, and they weren't yet eligible. What you can see is that before the pandemic, there were about almost 1,600 pulmonary exacerbations being reported in the registry. But once Trikafta was approved, there was a marked decrease in pulmonary exacerbations, and that was even before the peak of the pandemic when everything shut down in March of 2020. So it really was changing exacerbations even in the real world. And in those studies that I talked about, we looked at the big things that we usually think about in CF, so FEV1 and body mass index and quality of life, but other effects weren't actually studied. So we asked here at National Jewish, does it actually impact sinus disease? Because we know about half of adults report that they have significant sinus disease. So on the left, I'm showing you a sinus CT of someone before they started Trikafta. And because their sinuses are supposed to be air-filled, you can see in these areas in red that there's a lot of mucus and inflammation in this person's sinuses before they started Trikafta. And then after 6 months, you can see air again in all those spaces where there's supposed to be air. So it really did impact people's sinus disease. And on average, there was about an improvement of 24% in the amount of inflammation in people's sinuses. And we also asked them about their symptoms, and you can see that on this symptom score, there was an early decrease in people's symptoms, and that was maintained over the first 6 months of the study. Now, this study is ongoing, and we are currently collecting the data for 2 years to see if people's sinus CTs remain improved or even get better, and if their sinus symptoms are improved even out to 2 years. And there are a number of other really large studies that are going on to see what is happening in the real world. So the CHECK study is looking at changes in sweat chloride over time as people transition to different modulators. The PROMISE study being done here in the US and the RECOVER study being done in the UK are both looking at long-term and other outcomes like the impact on diabetes, for example, and the impact on mental health of the long-term use of modulators in the real world. And then finally, BEGIN is going to look at baseline in young children, and then hopefully, ultimately, what happens when they are able to take Trikafta or Alex/Tezaiva. Now, there is really interesting data from CHECK and PROMISE that I'm going to show you in these upcoming slides. The other studies have just really started, so I won't show you data from those quite yet. So this is data from CHECK, and on the y-axis is sweat chloride concentration, and then on the x-axis is their baseline or their historical sweat chloride, and then what happened after they switched to ivacaftor, and then what happened after they switched to Trikafta. So you can see that on average, people's sweats were up close to 100, as you might expect, but then when they went on ivacaftor, there was this significant decrease. But importantly, even after being on something that was very effective, ivacaftor or Kalydeco, when people switched to Alex/Tezaiva or Trikafta, there was even more of a decrease. And that actually supports our approval here in the US for people who have one copy of F508, regardless of what their second mutation is. Now, again, PROMISE is a study that's enrolling people who were able to start on Alex/Tezaiva or Trikafta once it was approved. And we always wonder, will we see the same results in the real world that we saw in the clinical trials? So this was early data from PROMISE showing that people did, in fact, have improvements in their lung function and their sweat chloride and their quality of life that were on par with the phase 3 trials. And then if you look forward to what happened over time, you can see that the results are quite well matched to what we saw in the clinical trials for lung function, for sweat chloride, and for quality of life. Again, just showing how effective these drugs are, even when given in the real world under less stringent conditions. Another thing that we didn't look at in the phase 3 trials was the impact on people's infections. So this, again, data from the PROMISE study is looking at what happens to people's infections in their airways when they're on Trikafta. And you can see that for Staph aureus, Pseudomonas, and Stenotrophomonas, there was a very early decrease by 1 month in people's infections. And on average, those remained lower than they had before starting Alex/Tezaiva. Again, very exciting because we know in CF that infection and inflammation, that vicious cycle, really damages the airway. So it's exciting to see that we may be able to decrease infection. Now, of course, Trikafta is not an antibiotic, so why would that happen? Well, this data also from the PROMISE study being led partly by Dr. Steve Rowe and by Dr. Scott Donaldson is looking at mucociliary clearance and mucociliary transport. So how well those cilia in our lungs beat back and forth and move things out of the airway. So you can see that before starting Trikafta, this was on average what people's mucociliary clearance looked like, and then afterwards it got much better. So it's very likely that the reason people have less infection on average is because they're able to move it out of their airways because their mucociliary transport is better. So what does this mean for the future? Well, the Cystic Fibrosis Foundation has used data from the registry to project what they think the future of CF will look like based on these improvements in lung function, because in cystic fibrosis, we know that lung function is what we call a surrogate for survival. In other words, the higher somebody's lung function, the more long we expect them to live. And so this is data that's looking at those projections. On the left side of the screen is what's happening in the pediatric population and what we expect to happen. And on the right side of the screen is what we expect to happen in the adult population. Green represents healthy lung function, so over 90%, and then 40 to 90% lung function is considered moderate disease, and that's in yellow, and then less than 40% is considered very severe disease, and that's in dark blue. And over the next 20 years, what we expect to see is about the same number of kids with CF, about 16,000, but more of those kids are going to have a healthy lung function. On the other hand, in the adults, what we expect to see is not only having more healthy lung function and following in that healthy or moderate disease, but because we expect people to be living so much longer, we expect the adult population to increase from around 18,000 at the end of 2016 up to 30,000 in about 20 years. So very much a change in what we expect to see in the future for people with CF as they live healthier and longer lives. So one question comes up is, what do we expect people to do with these longer and healthier lives? Well, one thing people have told us over and over is that they want to do less therapies. Chris talked about the fact that he still does a lot of therapy in spite of being on Kalydeco. But one of the questions is, if we treat people with these highly effective modulators, especially early in life, can we start to withdraw some of the really time-consuming therapies that they're doing, like Dornase alpha, Pulmozyme, or hypertonic saline? So there are two studies going on right now. One is Simplify being done here in the US, and one is CF Storm being done in the UK, to look at what happens when people stop their hypertonic saline and or their Pulmozyme. So the study in the US obviously started a bit earlier because we had approval here in the US about a year before they had approval in the UK, but we should get data from these studies in 2022 and 2023 so that we can figure out whether or not it's safe to stop some of the time-consuming therapies. Now, these are trials. We also really want the perspective of people with CF. Many of you are probably aware that there's a thing called Community Voice, where people with CF can sign up and give their opinions about clinical trial design and things that are happening in the CF community. Using Community Voice, there are two studies that are getting people with CF involved. Quest is a study that's going in parallel with Simplify, and it's really going to ask people about their experiences with withdrawing therapy. And then Hero 2 is an app-based study that is really looking at how people are changing their therapies in the real world. And it's going to link it to registry data. So those are studies that people with CF will have a great deal of input about, and encourage you to sign up, because Hero 2, you can very easily sign up for it, regardless of being in any other study. And Quest is for those people who are in Simplify, but you can go to cff.org and look for those studies online. So another consequence of people with CF living longer and healthier lives is that more and more people, as again Dr. Mogezel referred to earlier, is that people are thinking about having kids. Now, of course, about 98% of men with CF are infertile, although there are techniques that we can use to help men have babies. But women with CF, we think, are able to have babies even easier on Trikafta because there is CF channel in the cervix. So when you treat people with Trikafta, it affects their chloride channels all over their body. And we do, in fact, think that it's easier for women to get pregnant. Now, Dr. Mogezel showed you a slide earlier. This is a similar slide looking at pregnancies over time in the US CF patient registry. The difference with this one is that I am showing you times when there were phase 3 trials of modulators going on. And you can see that with each phase 3 trial, there was a little dip in the number of people who were getting pregnant that had a boom after. And of course, with Trikafta, as Dr. Mogezel said, we have seen this huge boom. So people in 2019 had about 310 pregnancies, and that went all the way up to 619 in 2020 following the approval of Trikafta. Now, one thing that we don't know a lot about, except for the data that was done in animals, is what happens to the baby if the mom chooses to stay on Trikafta, or what happens to the mom if she chooses to stop her Trikafta. Does she get sick? And so we really need to get data on this as more and more women begin to have babies. So myself and Dr. Raksha Jain are conducting a study called the MAYFLOWERS study. So it's the maternal and fetal outcomes in the era of modulators. We're going to be doing this prospective multi-center study at 40 sites across the US with the hope to enroll almost 300 women and ask these questions. So how does pregnancy impact mom's health? How do her obstetric outcomes look? So does she need a C-section, or is she able to have the baby without a C-section? And what is happening with the baby? And we want to know these questions, whether she decides to stay on her modulator or if she decides to stop them, or even if she's ineligible for a modulator. So this study began enrolling at the end of September. And again, we hope to enroll about 300 women. So women are being enrolled in the first part of pregnancy if we can get them that early, but even out to the 3rd trimester. If a woman is identified as being pregnant and wants to be in the study, she can enroll. And then we'll follow her out, not only through her first year after pregnancy, but also all the way out to 2 years, really to see, does her health is it impacted by having a baby, and does it matter whether she stayed on her Trikafta or not? And also we want to know what's happening with the babies. So there are a couple of things that we know about ivacaftor, for example, or Kalydeco, and all the peds parents who have their children on ivacaftor or Orkambi or tezacaftor, ivacaftor, Symdeko know that they're supposed to get cataract exams for their child because there was data in animals that said that there may be a predisposition to developing cataracts. So we want to know, are any of these babies developing cataracts? And also we want to know how much exposure are they getting to Trikafta. So we'll be measuring the levels of Trikafta in some of the babies and their moms if they give permission to do that. Now, I did say also that people, not just moms, but people are asking about getting pregnant and doing in vitro if they're a man with their partner and having a baby. And there's really not very much data out there about how parenthood or having a child impacts the health of someone with CF. So in the UK registry, they do actually ask, since 2016, if a man had a baby with his partner through in vitro or however he chose to have a child. And so we decided to collect the data from the registry with the permission of the people at the UK registry and ask what happens to the health of people compared to the year before they had a child and the year after. And so what we saw was there was in fact a decrease in people's lung function, a little bit of a decrease in their body mass index, and an increase in exacerbations in the year after they had a child. And this was somewhat mitigated by people being on modulators. And because this was 2016 to 2019 in the UK, people were not on Trikafta. So this gave us a hint that maybe there is something about being a parent, probably because it's exhausting and there's a lot to do and people are still trying to take care of their CF and they're being exposed when their children go to daycare and school. So what we really want to know is how do we intervene to help people not have declines in their health when they have a child. And so led by Tracy Kasmersky, we're hoping to do a study that's going to be prospective, looking at the impacts of parenthood on people with CF in the modern era and looking for ways to help parents have a really healthy trajectory even after they have a child. So in the last 20 minutes or so, I've shown you like some of the great impacts that we've seen with highly effective modulator therapy. And so some people might say, well, are we there yet? Are we done? And the answer is definitely not done yet. So one of the issues is about access. So I mentioned earlier that Dr. Dorothy Anderson was the very first person to describe the pathological and clinical entity of cystic fibrosis. And unfortunately, she was basing this on the autopsies of children who had died from CF. But in her first paper where she described all these clinical cases, she noted that there was a child who was Black and a child from Puerto Rico. And she said in her paper that the racial and geographic distribution of CF was wide, but somehow that message was lost along the way, and CF was often thought of and taught as being a disease only of white people. If you look at the worldwide map, we know that there are cases of cystic fibrosis all over the world, regardless of people's racial and ethnic ancestry. But one of the consequences of the fact that it was thought of as a white disease is that people of color don't have as much access to CFTR modulator therapy, and they're often late diagnosed. So one group looked at the number of people based on their genetic ancestry of how many copies of F508del, and they looked specifically at how many people had no copies of F508del, which of course was the first approval for Trikafta. So in people who were white, only 10% of people did not have a copy of F508del. But if you looked at people who were Hispanic, Black, Asian, and Native American, they were much more likely not to have a copy of F508del, making them ineligible. And to really specifically look at more modern information, Doctors Megan McGarry and Susanna McCauley looked at CF registry data and looked at who was eligible for any of the currently approved modulators. And they showed that while 92% of white patients with CF were eligible, only 76% of Hispanic and only 70% of Black people with CF were eligible for CFTR modulators. So people who were late diagnosed and had difficulties with accessing care were also less likely to qualify for this really life-changing therapy. So one of the things that the CF lab is doing in Bethesda is trying to figure out, are there other mutations that are responsive to Trikafta and the other modulators that have been approved? And what they've shown so far is that about 66% of the mutations that they've tested are predicted to result in some clinical benefit. And we're really, really lucky here in the US, where there's precedent for the Federal Drug Administration, or FDA, to approve drugs if they can be shown to improve outcomes in cells. So we look at human bronchial epithelial cells and ask whether chloride transport is improved, and they are willing, because there's such a tight correlation between improvements in human bronchial epithelial cells and what happens in the clinic, to approve drugs based on those findings. And in December of 2020, there was actually an expansion of the label of approval for Trikafta based on some of this data in cells. So we're continuing to try to look at those people who have really, or cells, look at cells from people who have really rare mutations and weren't in clinical trials, to try to expand their access to CFTR modulators. And you can see that this really did make a difference for people of color who were not eligible based on the initial approval. So if you look at the left side of the graph, we're looking at how many people based on their genetic ancestry were eligible for Trikafta. So here you can see that the majority of people who were white were actually eligible, but a lot of people who were Black and Hispanic were not. But once the label was expanded, it really did increase the availability to people with more rare mutations who were of color to get Trikafta. Now that's all about the approved modulators, but what about upcoming modulators that may be approved in the future? So AbbVie continues to look at their triple combination. It's in phase 2 right now, and hopefully we'll have results from that later this year, or later in 2022. And then many of you may be aware that there is another triple combination from Vertex that is going to be tested in the clinic in phase 3 trials. So it's a combination of a drug that is called VX-121 that's similar to elexacaftor, also tezacaftor, which is in Trikafta, and then a deuterated form of IVA, so it has an extra chemical group on it to make it last longer. So it only has to be taken once a day. And those trials have already started. Now, the modulator therapies are for people who actually produce the CFTR protein or the chloride channel. People with nonsense or stop mutations have an early message saying, don't make the protein. And so the cell stops making the protein. So we're trying to find ways to convince the cell to keep making that protein. And one of these ways is by giving it a medicine that tells the protein or the cell to just ignore that message, ignore the message saying stop and keep going, keep making the protein. And this drug, ELX-02, was shown in cells that if you gave it to cells, that it did actually continue to make the protein in the setting of this drug. And recently, as of the 17th, in fact, of November, hot off the press, they did release their phase 2 data and show that there was an improvement on average of about 5.4 millimoles in people's sweat chloride. And you think, well, that's not a huge amount. Well, you know, when we actually gave only one component of, or can be the lumacaftor component, to people with F508del, we found out it wasn't enough. You couldn't just make the protein or get it to the top of the cell. You needed another drug, the ivacaftor portion, to make it work better. And so ELOX has actually looked in cells and said, what happens if we give not only ELX-02 to help make the protein, but then give ivacaftor in addition to make it work better? And you can see that there was better chloride transport with the combination of both ivacaftor and ELX-02. And that led to them amending their current trial to include 1 week on just the ELX02 and then 4 weeks of ELX02 plus ivacaftor. And we're hoping to get that study started very soon. So those are things that are happening right now. But of course, as Chris said, we don't yet have a cure for CF. And ultimately, we want to make sure that we have a cure for every single person with CF, regardless of their mutations. And recently at NACFC, Dr. Hilary Valerie and Dr. Martin Mentz gave this great analogy about what if CFTR were a car? How would you fix it if it had problems? So if you think about the car being the CFTR protein or the chloride channel, and CAR problems, the CFTR mutations, how would you go about fixing it? So one way to think about that is mRNA therapy. So not the blueprint, but the specific messages about how to make the protein. And so you might give a therapy to fix the message. And that's like a rental car because you would have to give it multiple times. You couldn't just give it once. You could do gene therapy and replace the gene entirely, and that would be like getting a whole new car. So you would hope to do that once and never have to do it again. And then there's the possible opportunity of gene editing, where you actually go in and you fix the gene in the cells, and so then it's repaired. So we're trying to think about doing all of these things in the future, but really exciting is that we hope to start in the first quarter of 2022 a study of a viral vector, so basically infecting the cells with a safe viral vector that carries in the correct message. And this study that we hope to start in early 2022 is sponsored by 4D. They have looked in non-human primates and shown that they can give a single aerosol dose, so inhaled therapy of their drug, and they didn't see any adverse findings, inflammation, because in the past, the therapies that we use caused a lot of inflammation in the lung and could make people feel very sick. And so we wanted to make sure in the non-human primate model, we weren't seeing a lot of inflammation. They did not, well, they were given steroids at the time of the treatment. And importantly, they were able to see that there was actually expression of the corrected CFTR in all areas that they looked at in the lungs. So in the trachea, in the bronchial epithelium, and in the air sacs and the alveoli. So the brown represents the fact that it's actually there. So again, hoping to start this therapy or this trial for this therapy in 2022 in people initially who don't have modulator access at this point. And again, very fortunately, there are lots and lots of companies that are looking at various ways to help us fix CFTR permanently. So again, there are more people looking at restoration, so the modulators, but really there are a lot of groups looking at gene delivery, gene editing, models and tools about how we get it properly into the cells. And then there are companies that are looking at very early preclinical development, trying to help us find a cure for everybody with CF. Now, of course, people who have established disease do still have symptoms and signs. We're looking to see if we can maybe have them stop taking their pulmozyme or stop taking their hypertonic saline, but we do still need to treat the signs and symptoms that they're having while we continue to look for better and better CFTR modulators and to look for a cure. And fortunately, there's a very robust pipeline from the CF Foundation. So these are the approved therapies at the top, and these are all the phases of trials. So early preclinical work, phase 1 often tested in people without CF, and then phase 2 being the test in people with CF, looking for early signs of the drug working, but really looking at safety, and then the large phase 3 trials that help us get drugs approved. So we're still looking at things to improve mucociliary clearance, to decrease inflammation and infection, and to improve people's nutritional outcomes. So lots and lots of work still happening. So over the last 35 minutes or so, what I hope that you've heard from me is that there is highly effective treatment for the basic CF defect for about 90% of people with CF, and there are profound impacts on health that are at least we know stable over the intermediate term. We'll continue to follow these people who are in these trials over time to see if the results continue to be sustained and the drugs continue to be safe. There are numerous ongoing real-world studies that are going to look at broader impacts of highly effective modulators on people with CF, so beyond just lung function and BMI and quality of life, but other outcomes like impact on mental health, impact on sinus disease, impact on diabetes, and looking at parenthood and pregnancy. Again, there's a really robust pipeline to make sure that we are developing therapies that are very effective for every single person with CF. And there are numerous shots on goal to develop a cure for cystic fibrosis. So with that, I will stop and say thanks to the CF Foundation and the CF Therapeutics Development Network for all the work they're doing, but really importantly, people with CF and their families who are participating in these trials, as well as all the doctors and other care center providers who are helping us get all of this research done. We couldn't get forward without you. And with that, I will stop, and if there is time, take a few minutes for questions. Thanks for your attention.
Thanks, Jennifer. That was really fabulous. A great overview of what's going on and what the future might bring. There's one. Please put questions in the Q&A, and we'll answer those as we go along here. The first one was, you talked about simplify and lessening therapies, but there's a question about what about airway clearance? Can we do something about that? That's a tremendously time-consuming thing, and is anyone studying that?
That is a really great question, and I think when both people with CF and doctors were asked, because Dr. Nichols and colleagues really wanted to know what is the thing that people really want to stop and what are people willing to let their patients or advise their patients to stop. And I think people were nervous about airway clearance for a number of reasons. And right now people do all different kinds of airway clearance. And so it was a little bit complicated to design a study looking at discontinuing airway clearance, but I suspect in the future that will be something that's studied, and we're going to collect some of that data through the HERO2 study, because people with CF are going to tell us what they're doing and what they're stopping. And so we'll find out some data from HERO2 about that.
I know our physical therapists would very much say that exercise could be utilized in some way, and exactly how that should be utilized is still unknown. Another question was, are those your puppies that in the picture?
Yes, those are all mine, age 14 years to age, well, now 14 months, because that was an older picture. No kids, just
dogs. You have your hands full with that group. I've got my one, which is more than enough for me. We had some questions that came in. We asked people before the webinar when they registered about questions as well. And one was about side effects of Trikafta, particularly mental health issues. What has your experience been, or what research has been shown to be about this?
That's a really great question. I look back at some data from the ATS that was published there in, I feel like maybe 2018. And there was a really interesting abstract, because there was a center where they basically switched everybody from their Orkambi to Symdeko. And they showed that 5 out of their 44 patients had to go back on their Orkambi because they were having mental health side effects from switching to Symdeko, things like feeling out of body and feeling more anxious and losing sleep. And so we didn't really measure that in the phase 3 trials, but it is being looked at in some of the real world studies that are ongoing. And we certainly have heard people say that they feel more anxious or they're having some insomnia on Trikafta. Now, it was really hard because, again, here in the US, there was the approval in October 2019, and then the pandemic was raging shortly thereafter. And so we weren't sure whether people were feeling anxious because of their Trikafta or because the world seemed to be falling apart at the moment. And so now that it's been a little bit longer, and even though we're still dealing with the pandemic, it's settled out a bit, we are continuing to hear people saying that they're more anxious. So it's something that's going to be looked at in the phase 3 trial of 121. We're going to be really focusing on whether or not we still see that side effect. And again, people are looking at it in the real world. So we're hoping to figure out, is it really the Trikafta? And then what do we do to mitigate? We've here at National Jewish really tried to treat people through it because people's lung function and pulmonary exacerbations are so much better. We're reticent to stop it. So we have tried to use more of our help from our mental health colleagues, as well as sometimes treating people with medications for their anxiety.
No, it's a really important point. I know that we've seen in pediatrics some issues, and the adult group has seen some as well.
Yeah.
We've also had the opposite happen too, with people who are actually, from a mental health issue, better on Trikafta.
Right.
The other thing you didn't comment on, but it was also a question, what about the use of Trikafta after lung transplant?
Yeah, that's another really great question. And Kathy Ramos at University of Washington is actually doing research in that area and presented some of the data at the North American Conference. Again, I'm like losing track of time. That was 2 weeks ago or a week ago. But you know, of course, people who have a lung transplant still have CF everywhere else in their body, and particularly their sinuses still continue to be a major issue for a lot of the adults who are transplanted. And so what her data showed, so she basically looked retrospectively at data of people who had a transplant and what they had happen when they got on Trikafta, and they found that people's sinus disease did actually improve. But a lot of people continued to have GI issues, gastrointestinal, and if they were going to stop their Trikafta, it was usually for that reason. And so why that's the case more so in people who have had a transplant, we're not really sure. But of course, you also have to think a lot about the drug-drug interactions. But really, people who stopped it, in her study at least, were stopping it because they were having a lot of GI side effects. Now, she also looked at people who had transplants for other organs. And again, people did have improvements in their sinus and pulmonary symptoms, but more often they stopped it because of their GI side effects. So something that's going to be ongoing, and people are going to need to continue to look at this question. Although, as you pointed out, the number of transplants is much, much lower than it has been in the past.
No, that's one of the really remarkable things. And as you say, it is a little bit confounded by the COVID pandemic, where people were taking precautions against getting viral infections. And we know that viral infections do lead to exacerbations.
Right.
But we've had a huge drop in the number of people that are hospitalized, which I think only means that people are going to get healthier from now on.
Right.
When you think about the ELOX trial, the new treatment period that's going to utilize ivacaftor, when do you think people expect results from that? When will we know something from that information?
You know, I suspect that people will be excited for the opportunity to be on ivacaftor in addition to the ELX02. So I think people will enroll in it fairly quickly once it's actually started. So I would say by next year, we should have results of that study.
Are there other questions or thoughts?
I'm trying to look in the chat here really quick too, to see if there's. But yeah, actually somebody pointed out that in Plenary 2 is where they talked a lot about the CAR analogy and went through all the gene therapies in a lot more detail. So you actually can watch that on YouTube right now, I believe. So if you just go to the CF Foundation website and look up the former CF conferences, you can go to Plenary 2 and watch the whole 45 minutes or so where they spoke a lot about the gene therapy options.
No, that's a very good point. All the plenaries are online for people if you didn't get to see them at the North American CF meeting. I'm very grateful to have you talk and tell us about what's going on now and what's going on in the future. And we look forward to another year of really exciting results, I think, from some of the studies that you talked about, and moving the ball forward on getting therapies for everyone. So thank you so much. I want to again thank Simone and Chris and Emily for putting together the technical aspects of the Family Day, and for getting participants to have books and to have Casey Cares. As I said, we'll be distributing the books over the next few weeks. If you need to get a Casey's Care form, you can do that from their website or contact Emily. So thank you everyone for joining us.